Hello, good morning, everyone. A very warm welcome to all our respected members and students joining us from different parts of India. I am Kanchi Vaishne, and it's my pleasure to be the moderator for today's International Live Webinar organized by Neuroptech. We are truly delighted to have all of you with us today. Today's webinar focuses on an exciting and emerging area of optometry, that is, an optometrist role in posture, gait, and beyond. As we all know, vision is not just about seeing clearly, it has a profound impact on posture, balance, movement, and overall functional performance. Today's session will help us understand this fascinating connection and its clinical importance. Now, it's my privilege to introduce our esteemed speaker. We are honored to welcome Mr. Deon Hattingh from Johannesburg, South Africa. Mr. Hattingh is an experienced optometrist with a special interest in behavioral optometry, binocular vision, pediatric optometry, vision therapy, and dry eye management. In today's webinar, he will explain how optometrists can play an important role in improving patients' posture, gait, and how visual assessment and management may even help reduce neck pain and in certain cases. Sir, we are truly grateful that you have accepted our invitation and taken the time to share your valuable knowledge and experience with us. Without taking much of your valuable time, I would like to invite Mr. Deon Hattingh to deliver today's session. Sir, the virtual stage is all yours. Welcome, sir.
Hello, thank you for inviting me, and I'm absolutely elated to present to you guys. This is a topic that's very, very dear to my heart, and yeah, so let me share my screen. This one, yeah, there we go. Can you all see me nicely? Because I don't know if you guys can see me.
Yes, sir, you are visible
Um,
and your skin tone.
Let me just see. Why didn't it go to? Didn't go to. There we go. Okay. So yeah, So what we're looking at is vertical and cyclovertical heterophoria. So vertical phorias are very often overlooked um, because it was very rare. Actually, not as rare in my experience. I don't know, maybe it's just I see a lot of patients that come to
ये
me
कैसा आएगा?
because I specialize in binocular vision and such issues that that I see a lot of vertical deviations because I market and attract that kind of patient. So, what is the symptoms of vertical deviations? You can have dizziness, you can have nausea, you can have poor parking. So, I always ask my patients how is your parking? Because if they park very skewly, it tells me a lot about their spatial awareness and their depth perception. Your case history is so important in identifying certain issues that the patient might not be aware of. So sometimes they can experience intermittent double vision vertically, vertical double vision. They lose their place while reading. This is especially important when you think of children and you ask them, do you lose your place while reading? And that is then very important to make sure that there's no vertical deviation. They can have car sickness, skew handwritings, headaches as a direct result of the vertical deviation itself and the asthenopia it causes, but also sometimes when it causes neck pain, obviously you can have a headache um, because of the neck pain. But also clumsiness, that's also important. A question I ask all my patients is, are you clumsy? So vertical deviations can be more symptomatic than horizontal deviation. And I would like to put emphasis on that and say that vertical deviations can be more symptomatic than horizontal deviations. In most cases, vertical deviations, phorias and tropias can result in an abnormal head posture. So if you look at this example of this man here, this is obviously a quite a severe case. But when you look at and when you look at the eyes itself, sometimes you can see that one eye is higher than the other. You can even see in this gentleman, when I mean the casing of the eye, the orbit is higher than the other. You can see in this gentleman, his actual orbit is higher than the other. And you can actually see the eye, the tropia, very clearly there. But you can see that his face has grown skewy and his orbit has grown, the one orbit has grown higher than the other because the body responds to stress, okay, and grows in response to stress. If you take fundus images, the the macula and the optic disc should be more or less almost like a straight line, it just should reach the bottom, the bottom of the cup, just a line. But you can see clearly that these eyes are twisted vertical deviation. But these are very obvious deviations, and vertical deviations can and head postures, abnormal head posture can be so slight you must look closely, very closely at these head postures. You can see also in these children, you can see in this boy as here, his actual face is asymmetrical. And you can see in this little girl, she will most likely need surgery, and we would need to get ophthalmologists involved. So there's different ways to test for it, but something that's very helpful is when you look at the patient and you see an abnormal head posture, you can let them stand and look at them, and then, ask them to look at a target. You can maybe put a single optotype on the visual acuity chart and ask them to close their eyes. Then you will see that the posture corrects. When the posture corrects, is definitely the posture is because of the eyes and not the musculoskeletal issues. And other method is you let them lie on the ground or let them lie on a bed or something like that, and I'll ask them to look above at the light. Let them close their eyes maybe for 5 to 10 seconds so that the eyes, ask them to see if they see 2 lights before they see 1. And then obviously you ask them, and that's a question I always ask in my case history, is do you experience neck pain? And most importantly, do you experience neck pain more on the one side of the neck or the shoulders? So this is myself. This is a video of myself. I hope you can see very clearly that my head posture corrects as soon as I close my eyes. And I hope that you can see clearly that when I put back on my glasses, my head posture is being corrected through prism lenses, base up, base down, prism lenses. And you have no idea how significantly this has changed my life. And it's funny that I studied optometry, and only when I worked for a behavioral optometrist that she detected this vertical deviation. And yeah, she detected this vertical deviation, even though I was in optometry school and nobody detected it until I started working in behavioral optometry. And she detected it, and my neck pain has reduced so significantly. That's why this is so important to me, because I know how significantly it can impact the way I function. When you get a headache and you get neck pain, it really impacts your ability to function. And that's why this is very important to me. So you get dissociated phoreas and you get associated phoreas and you get fixation disparity. So dissociated phoreas is under biocular division. That's your covered test, your Maddox rod, your Fongrave, even though I do not like the Fongrave test. Associated phoreas is under binocular vision conditions. And the gold standard is, of course, your mallet unit, which is very hard to find. You get your Schubert test and you get other tests, which I'll show you later. Then you get fixation disparity. Now, what's the difference between fixation disparity and associated phoreas? They're basically the same thing, but fixation disparity is measured in the seconds of arc, and associated phoreas are measured in prism diopter. But fixation disparity is a little bit more sensitive in detecting deviations, horizontal or vertical. The way I like to think of it, to simplify it, is that the dissociated phoria is your full deviation, and associated phoreas is the deviation, the residual deviation after the patient has used all their fusional reserve. Is that so? You might get a dissociated phoria of 8 prism diopters and an associated phoria of 1 prism diopters, meaning the fixation is 8 prism diopters, but now they have fused the images and they still have a residual deviation of 1 prism diopter, which should be corrected. So you get different tests to test for this. The mallet unit, the last time I saw a mallet unit was at university. If someone can tell me where I can find a new mallet unit, I'll be very happy, but because it is the gold standard. But there are some things you can find on Alibaba or other website which called a vision tester, but it's mostly for near. But I don't know the validity of those tests and how good they are, because they're simply not necessarily the original mallet unit. Then you get a test called Schubert, and I absolutely love this test. I think it is fantastic for detecting any sort of deviation, especially in children, because you can ask the patient, what do you see? Okay, then they say, I see a circle and I see a plus. Sometimes if they don't see the circle and don't see the plus, they won't see, they have suppression. Then you ask them, is this cross in the middle of the circle like a bullseye? Like perfectly? Or is it a little to the left, a little to the right, a little higher, a little lower? And they can so easily identify and say, listen, this is a little bit higher, a little bit lower. It's very important to ask, is it moving? And when they say yes, is it moving? Is it moving more up and down or moving more left to right? And when you add prism lenses, then you ask, is it more stable? Now that I've added the prism lenses, obviously, in the Schubert test, if it's to the left, it's a exophoria. If it's to the right, it's an esophoria. If it's up, it's a hypophoria, and if it's lower, it's a hyperphoria. So it's totally the opposite. Then I have this lovely, lovely test. I don't know what to call it, which is for me very similar to a mallet unit that I have on my Neuroptech screen, and I absolutely love it. You ask the patient, is you ask the patient, you ask the patient, do you, what do you see? Do you, and then they say they see arrows or they see a cross. Say, tell me, this arrow, is it pointing to the middle of the dot perfectly, or is it a little to the left or a little to the right? And then I go on, I just go on in a clock and I say, and this arrow, is it a little higher or a little lower, or is it pointing perfectly to the middle of the dot? And so on and so forth. But some patient would say, no, it's in the middle of it's in the middle, and it's like it's like even is it perfectly? Because even the slightest deviation is important, and some patients would not think it's important. Ah, it's a little off, but it's almost in the middle, so whatever. So this is a fabulous test, especially also to take very small deviations. Then you get a program called Spectrum. I'm not affiliated with them. I also don't use them, but it is fabulous. I've used it before at the other practice I used to work before I opened my own practice. And it's a program you can download on a computer and you can use it on any screen. So you can put any screen in the distance and you can use this program from the computer, connecting the screen with an HDMI cable, and you get various different tests on this program called Spectrum. And you can see that this is specifically just for vertical deviations, and you add Prism until the patient says that the the, the lines are aligned. Because if you add, but you must add in both these cases, I forgot to mention, the mallet units, I believe you use polarized lenses, if I'm not mistaken, but I haven't used this in a long time. The Schuber and this test that I just mentioned, you use the red-green targets, red-green lenses, and then you use loose prisms. Use loose prisms and not a prism bar. Use loose prisms. And then also with the Spectrum technology or program, you also use loose prism and you also use red-green lenses. You can use red-blue lenses, but red-green lenses work as well. Then for close by, for near, you get the Wesson card to test for fixation disparity. For associated phoria, you can use the Brock posture board. I know it's not very widely available. This one was made by one of my lecturers. She made it for us, and you get the Saladin card. So you also get an app called Smart Optometry, which you can also do the Schubert test on. The Schubert test they have a Schubert test on the phone or tablet that you can download, the Smart Optometry app. I'm also not affiliated with them. It's just something I use in the practice. But like I said, fixation disparity can detect more subtle deviations. But I also then use loose prism lenses to neutralize the deviation. So obviously this card is now in landscape. When you're going to test the vertical deviation, I use a Wesson card and a Brock posture board. I don't have a Saladin card. You will often see in the Brock posture board that you find the vertical deviation. You don't find the vertical deviation, but on the Wesson card you do find the vertical deviation. So obviously you will turn it into a portrait mode, and then you ask do you see my ruler? Do you see my arrow? On what line on the arrow is the ruler pointing? If they say the long middle line, you can ask them, tell me then, is it perfectly on the long red line or the long line? Sometimes they see the lines as black, or is it a little higher or a little lower? And then you can say ever so slightly. And then they would maybe mention that, oh, it's slightly a little bit higher or slightly a little bit lower. For cyclotorsion, you can measure the torsion of the double Maddox rod, where you have the red um, Maddox rod um, placed with the lines facing up, and you have the white Maddox lens. And then you will see the patient will see two lines, a white line and a red line. The patient may see them as skew, and then you ask it to turn the dial on the trial frame until you see the lines going parallel. This is a very difficult test. Sometimes it's rare. I struggle to get the patient to see the white line. I don't know if I think it's because my room doesn't get dark enough, but it's also good to see like how much torsion do you see. But in any case, even if there's torsion, it will come up on these tests as a vertical deviation, even if there's torsion. Okay? So now this is very important, and I want you to remember this for your life. I want you to focus on this, and I want you to remember it with all your brain power. Is if there is both a vertical and horizontal deviation, you correct the vertical deviation first with loose prism lenses. Okay? Very often, correcting the vertical stabilizes the horizontal. Let me go back to my test. You will see that the patient says the top line is a little to the left. This line is a little higher. This line is a little bit to the right. This line is a little bit lower. You correct the vertical deviation, and all of a sudden you add a 0.5 base down in the right, for example, and all of a sudden all the lines are pointing perfectly to the dot. So that's very important to remember, to correct the vertical deviation first before you correct the horizontal. But you won't always prescribe. So doing with fixation disparity testing or associated disparity testing, at the moment, that's the most evidence-based way to prescribe Prism. But you won't necessarily prescribe the full Prism, because remember, these patients have habituated to this deviation for probably most of their life until it became symptomatic. For most of their life, it wasn't symptomatic, maybe in adulthood, or, well, I see it a lot in children, but they can still be quite used to it. And then you just put in the prism that makes them comfortable. And very important is that you correct the distance deviation. If you correct the vertical deviation, it might, most of the time, the near deviation is more at near than at distance, but it can also be the other way around. But if the patient, if you're going to make them one pair of spectacles, you can only correct the distance deviations. If you're going to do like a segmented Franklin bifocal, or what is Franklin bifocal, you can correct the distance and the near separately. But you give them the prism that makes them feel most comfortable. And sometimes they won't accept the prism. They're so used to it that they just don't want it. It makes them feel uncomfortable. But often when you see it, it's so lovely to see. So you put that lens in front of the patient and they're like, what did you do? What did you do? Because they suddenly feel so much comfortable, and you mitigate a lot of their symptoms almost instantly. So these are head postures that were corrected, or vertical deviations that were corrected with prism lenses. You will see on the left side, she wrote I love cats, and it's very skewy. With one base down prism in the left, she wrote quite nice and straight. So that's also one way that you can look, is you give them a blank piece of paper with no lines, and you ask them to write something in the middle of the paper. So they don't have the top of the paper to use as a guide to write straightly, but in the middle of the paper so they don't have any guide. Um, and that's also why I type out all my referrals because I write quite skewly. Because if you look now, if I look far away, you will see that my head is quite straight. But when I look close by, you will see that I have a tilted head. So I actually am considering of doing a Franklin bifocal for myself, even though it's quite ugly. But it works. It works wonderfully. Then you can also see this person. This, you can imagine that this is the same prism amount, but it makes a absolute massive difference. If you look at the top, I hate math. Once again, it's in the left. Interesting. And once again, they wrote the same thing, and it's absolutely straight. You can see that in the bottom picture that it's less squiggly wiggly. That's what I would say. You will see that this one on the top, it almost makes like a curve, like going up and down, inconsistent. And then you see when we're going like this, you will see it's much more straight. So imagine the difference you can make in a child's life because the teachers keep on yelling him, why aren't you writing on the line? And then, why are you writing so ugly? And stuff like that. And you can make an instant difference, instantly, because I added those prism lenses and suddenly they could write straight. But you will see once the child gets tired, very tired, he will write skewly again. Because when you're tired, the deviation is a little bit more than when you are alert and rested and stuff. That's why it's just sometimes good to do the patching test, where you patch the eye for an hour and then you measure the deviations. You will often see that it is much bigger. So look at this picture. You will see, I want you to notice, stare at this picture. Can you see how subtle this deviation is? And then when I change the picture, you can see the posture is straight. Can you guys see it? It's so slight. And this is what I'm talking about. And you have no idea what difference it in this patient, the feedback that we got, like how much easier it is for her to study now that we have corrected the slight vertical deviation. This is like a 0.5 base down in one of the eyes. I usually use base down, yeah, in whatever eye. It's usually easier to do that, to use the base down to see the corrected deviation. And you make a difference in this child's life because this person is a student. The
आले थांबले ते
symptoms,
का कोण करते गाणी रसिका
uh,
प्रियो नित्या
Pratibha,
अंबिका
Pratibha, can you switch off your mic, please? Pratibha, yes, thank you. And symptoms of complaining, I'm having such difficulty studying. I am, and then now she is studying so much easier. And just wonderful. You're changing people's lives by being attentive to any kind of deviation, whether it's vertical or horizontal, but you're being attentive. Look at this boy. You can see that even his body is a little bit skewed, but his head is very much tilted. And look how much more straight it is with his glasses. But even more so, look at the walk. Where is my why is it, where's my thing to say play? No. Okay, so it's playing both at the same time now. But I want you to see how much straighter he's walking, how much he's not walking, he's much walking straighter. I hope you can see that he's walking much straighter with the glasses on. He's also walking much straighter. This person, this child does not, could not fully correct the deviation because he started to see double vision. But the thing is that the moment he's straighter, because he has a body tilt as well. So we're trying to correct the posture. You can see how in the first video he walks a little bit more, a little bit out of balance. You can almost see he's a little bit out of balance. And when you look at the other video, you can see that he's walking. I don't know why it's not playing, not allowing me to play. I don't know if I can switch off my, like, I just want to see if I can, because I think it's because of my laser pointer. I'm not sure why it's not doing that. So let's go. But in any case, I hope you can see that in the second video, the video that's playing now, that he's walking straighter, he is more upright, his head is more straight, although still tilted, because if we corrected him fully, he saw double vision. But hopefully this will help him. The physios are happy because his muscles are not so tight anymore. They can work with him better, and then they can, when you are correcting the vertical deviation, you can also make other practitioners' jobs much easier, like the occupational therapist, and in his case, the physiotherapist, to do their job easier because he has these musculoskeletal issues because of the head tilt, but for other reasons as well. And then, I just want to put emphasis that the deviations can be very subtle. Even the slightest deviation can cause neck pain. And imagine how moody people get. That's why I like behavioral optometry, because you're not just looking at what is the prescription of the patient, what is the health of the eye. You are looking at how the vision shapes the world and behavior. Okay? And how can you improve their quality of life and improve how they function in this world? And that's why I love behavioral optometry. And that's why I love binocular vision and I love vision therapy. Although vision therapy doesn't really work for vertical deviation. You can try, it's just very hard. I mean, you can maybe train fusion, it's really hard. The best way, if it's a slight deviation, is prism correction. And if it's a very large deviation, obviously they need surgery. Okay, but if you look at this woman, this is a stock image. You can even see the watermark on this. This is a stock image. Look at this woman's posture. She is tilting her body to the left. Her head is tilted to the left. This is a stock image. And this lady is wearing glasses. But there's definitely a vertical deviation here. And yeah. Scheinman and Wick says that a deviation as little as 0.5 prism diopter and higher should be corrected. A Vertical deviation of zero point 0.5 prism diopters and higher can be corrected, must be corrected because it can be symptomatic. I find that even correcting a 0.25 prism diopter vertical deviation can relieve symptoms, especially in those patients who have suffered traumatic brain injury and strokes and stuff like that. So I can want to quote what my colleague told me once and said when I just started practicing, and she said, "Don't be a weenie when prescribing Prism. Don't be a weenie. It's not a scary thing. We're always afraid of Prism adaptation, but Prism adaptation rarely occurs. Um, Sometimes if the patient wants Prism and Prism and Prism and Prism and Prism, there might be a neurological element that we might have to look into. But you can test for Prism adaptation. So what you do is you test the dissociated phoria, and then you correct the associated phoria using those different tests that I showed you. You wait 15 minutes, then you measure the dissociated phoria again. If the dissociated phoria is less, you will find that the patient will adapt to that prism. If the dissociated phoria is the same, they most likely won't adapt to the prism. So, but you also must think about the fact that, people fuse. So that's why I talked about the patching test, because people have fusional reserves. Vertical fusional reserves. So they're able to fuse. They are able to fuse, but so that's maybe why they are taking more Prism. They like the Prism. Not because they're really adapting to the Prism, it's because they actually have a bigger deviation. So maybe it's a good idea to delve a little bit deeper, maybe do the patch test, let them come back, put the eye patch on and let them come back an hour and do the same test again. Multifocals. You would be surprised how many non-adapts for multifocal is because of vertical deviation. And often they struggle to see in their intermediate portion. You would be surprised how much easier a person adapts to their multifocal. But not just vertical deviations. I'm putting a lot of emphasis on vertical deviations, but horizontal deviations are important too. But first we correct the vertical deviation, then we correct the horizontal deviation. And if a patient can't convert, what you also can do is when you correct the vertical deviation, do the MPC test again. Do the MPC test again, and you will see that sometimes their near point of convergence improves just by correcting the vertical deviation. See how important this is and how fundamental this is to correct the vertical deviation. So if you have a patient that struggles to adapt to the multifocals, check their binocular vision. You will see if you correct the vertical deviation, or if you put in basin prism, because often they can't see in their corridor because they're not able to converge enough. So you put in basin prism and they can converge enough to look into the intermediate, because the intermediate needs a lot more convergence than your near portion. But if you correct the horizontal deviation, you will see that you will have less non-adapts or patients that, I apologize. There is some reference. The Bible is obviously for binocular vision, Scheinman and Wick. It's a wonderful, wonderful book. I read it like it's a storybook. I read it for fun because it's really lovely. Um, yeah, questions, questions. Any
Thank,
questions?
thank you so much, sir, for such an insightful session and very informative session. If anyone have any question, then please type in the chat box. Sir will answer. Your presentation has given us a
Let me
deeper understanding of the important relationship between vision, posture, and gait and functional performance. We sincerely appreciate your valuable time and expertise. Everyone, please,
thank you.
if any question, then please type in the chat box.
Let me see.
Yes, sir. There is one question from Niharika Meena. What are the vision therapies to correct deviation?
Uh, so in terms of vertical deviation, you can use the same targets as what you would do your vectograms, your traniglyphs, anything, and you just turn them vertically. You just turn them around and do it the opposite way around. But let me just mention it again. It's very hard for this, for that. It's easy that's easy to train convergence, very difficult to train. How do you think a patient can voluntarily make fusional corrections for um, vertical deviations? You can try. There's nothing wrong with trying, but I feel like it will be a waste of money for a patient to come into vision therapy, and you try to work on something that will be very difficult for them and might not be possible for them. So prism lenses are the answer. Um,
There is one more question from Teja Subramanya. How many prism diopters can be corrected with vision therapy, and when do we need to have surgical intervention?
so it depends on the deviation. So I would, it depends on the patient. I've corrected deviations of like 10 prism diopters because the patient doesn't want to go to surgery. So it depends on the size of the deviation. It's just only so much prism you can give, before the patient sees double, where you have to use ugly prism like Fresnel prism and stuff like that. It's really a functional thing. It's something you have to discuss with the patient. I'm talking more here about subtle deviations. You will see that some of those vertical deviations that would require surgeries are in the like the 10 prism diopters range. But it's also important then again to do the patch test to test for the full deviation. So if the patient is able to fuse and you are able to correct it with prism lenses, then do so. But then you can have a discussion with the patient about surgery, but it's only like in that extreme cases like I showed you. If it's very subtle, that like that girl that was reading the book, there's no way we're going to do surgery for that. That is really unreasonable. But about, say, even, it really depends. It's a difficult question to answer, but like I say, it's also up to the patient. But you will see, like the patient like has a very large deviation. Is Schubert test similar to the Werford dot test? No, not really. No, it's not really the same because it measures the associated forias, and that doesn't necessarily test for double vision. So no, but you can, if the patient has atropia, and they see double vision, you can use the WRF4 dot test to see if they fuse when you add the prism lenses. You can see if they fuse with the prism lenses, but you do the Schubert test first, you correct the deviation, and then you say, but you know, if this patient see double vision, sometimes there's a trial and error issue over there where they literally, you can't do the Schubert test on them. You can't do all those tests that I showed you because they suppress, or they literally, the targets are this far apart, where you literally have to do like a subjective refraction with the prism lenses until you show them a vertical line or a horizontal line rather in terms of vertical deviation, um, and of optotypes, small optotypes, like say 6, 9 or something like that, and ask them add prisms until they see single. But also remember, is it a long standing or a sudden deviation? If it's long standing, obviously you can work with it. If it's sudden, you have to refer to a neurologist. And gyno measurement in the place of pre and post measurement. I don't know what a gyneometer is. I don't know what that is. I don't know what a gyneometer is. I don't know what it is. Sorry, I can't answer that question.
Hi, can I ask directly by speaking without
Yes, of
trying?
course. Yes, of course.
Okay,
Yes,
okay,
yes, you can.
okay. So, hi, Dino. I just wanted to know, like, there are some deviation like DVD, dissociative vertical deviation. So that deviation is visible once you break the fusion. So how do we correct this type of deviation with the help of prisms? Because most of the time these patients are not symptomatic.
If this patient is not symptomatic.
Yeah, DVD patients
Yeah.
like
If they're not symptomatic, I would consider not prescribing if they're not symptomatic. So, but often patients don't really, they think they're tired because they work really hard. And you need to poke and probe a little bit because they might say they're not symptomatic, but um, you need to poke and prod. It's like, because you get tiredness because of you work hard at work, and then you get extra tiredness because of binocular vision issues. So you have to really poke and prod to say, are you really not symptomatic? Because patients are so used to the symptoms that they don't think it's a problem. So you need to poke and prod a little bit more in making sure that there's no symptoms. But if there's no symptoms, I would consider not correcting. But like I said, if they have a vertical deviation, let them write something down. And if they write something down skewly, that's a symptom or a sign. That's a symptom. Even though they're not getting headaches or dizziness or whatever, they're writing skewly. So that's a symptom. And you always ask them, do you like to read for fun? If they don't like to read for fun, that's a symptom. That's a symptom because if anyone can read for fun if you find something interesting. And, or how long can you read for before getting tired? If they say like 15 minutes, that's a symptom because 15 minutes is a very short time to be able to read. So you need to poke and prod a little bit more. If I'm answering your question correctly.
yeah, yeah. Thank you so much for nicely answering this question because I never thought of that like patient is not able to read up for long time. Definitely patient may have symptoms, but still patient think that patient this is something is very normal.
Excuse me?
Yeah, patient most of the think that I'm able to read only up to the 15 minutes. Like it's very normal for me.
What is normal for you?
No, no. For the patient, suppose patient able to read up to 15 minutes continuously and without
That's
symptom. After that, he's starting symptoms, but patient thought that it is very normal. This is happen for everyone.
Yeah, they think it's normal. They think everyone can only read for 15 minutes.
Yeah.
So, you have to think about what the patient think is normal. And patients are also scared to tell you their symptoms because they don't want a very harsh diagnosis. So they're afraid of being diagnosed with something terrible, so they diminish their symptoms. So yeah, so be very. That's why case history is so important. That's why I ask, like, how's your parking? Parking skewy. Oh, okay, that's a symptom. That's a symptom. You could even ask them, say, yeah, so that's a symptom. So are they clumsy? That's a symptom. So there's more questions to be asked um, than more questions to be asked and more tests to be done to ensure that the patient does not have a vertical dilation or any other binocular vision issue.
So I have one another question. Like there are lots of patients they don't want to come for the office-based therapy for
I can't
convergence.
hear you. I can't hear you, sir.
Oh, okay. Wait a minute. Wait a minute. So there are some patients they don't want to come for the office-based therapy for convergence insufficiency. Like, how do you
Mhm.
manage this type of patients? Like, I used to give like some sort of cards and all. Like, how do you manage these types of patients? They don't have time to come the office-based therapy.
Well, I like to use dichoptic therapy. Dichoptic therapy is a game that with red-green glasses. Dichoptic therapy,
Yeah.
where they, I don't know if the apps are available. The free apps. It's called Game Bliopia, and there's a Amblo Play. It's actually developed for amblyopia, but it works very well for often when they just do the dichoptic therapy, they they are more inclined to do it because they can play a game or like Tetris or Snake or whatever, and that helps a lot. And then obviously your Brock stream is the best thing you can do for them, but sometimes the dichoptic therapy improves because it's forcing the eyes to work together as a team. There's also some paid vision therapy programs, online programs. They're not as effective as obviously as your traditional methods, but it does do something for them. I'm not affiliated with them, but there's one called Binox, and then there's one called iHero. It's the same people who it's the same people who made the smart optometry app, and that will also help because they do their own assessment on the program and they make derive a vision therapy program for that patient alone. But then I would still suggest a Brock stream. Do a Brock stream, not
Yeah.
pencil push-ups. Brock stream. You
Rockstream.
can make a Brock string. You can even make a Brock string with cool drink bottle caps,
Yeah.
and put it on the string.
Yeah.
A Brock string, and but patients are not compliant. There's only so much you can do. So for convergence insufficiency, it's very important to see if you can prescribe based on Prism and see if they can adapt to that or not adapt, makes improves their symptoms.
Okay, see, sometime what happens, like, what is your opinion on that? So if somebody have like convergence insufficiency, we can prescribe Prism or over therapy. Like, if they don't have time,
Both,
some, like, what is
both.
your opinion on Prism?
No, Prism, prescribe Prism. Don't be a weenie when prescribing Prism. Even if you're gonna do vision therapy, you prescribe Prism because vision therapy takes a long time.
Yeah,
So, but based in Prism relieves symptoms immediately. So you want to make them function based possible. And hopefully by the time you end vision therapy, they don't need the prism anymore. But you prescribe both. And if they can't come to therapy, you prescribe the prism and you try to give the dichoptic therapy. Often the patients do that, they play the game and the Brock string. So you have no idea how effective the dichoptic therapy. If you struggle to break suppression in a patient, dichoptic therapy is the way to go. You have those free games that I mentioned. You just search amblyopia games on your Apple Store or your Google Play, and you'll find multiple games that use red green targets. I have multiple. I even get these clip-ons from Alibaba, um, that you can clip onto the glasses that's red green to do the dioptic therapy. But but even then the patients won't play the game
Maybe.
because yeah. So but Prism is the way to go and to relieve symptoms and improve function. So that's the goal, is optimal efficiency is the goal, but you can't always reach that because patients are not compliant. Even patients who come into in-office vision therapy are not very compliant.
Uh,
But what can you do?
okay. For prescribing Prism, you also use the Shields criteria.
I do the Schubert test,
Okay.
and I do all the tests. I do the Schubert test. I do that other test with the arrows. I do all the tests to make sure that there's no vertical deviation, because one test might not pick it up, but another test may. You know,
Okay.
do
Thank you so
all
much for answering. Thank you.
pleasure. What do you mean? What base test to assess and prescribe Prism for physiological diplopia? Physiological diplopia is very important. Physiological diplopia is natural. They should experience physiological diplopia. Do you mean if they have full diplopia? If you mean if they have full diplopia, I'm not sure, because physiological diplopia, if you do bring a target closer, the target far away should be double. That's normal. I don't understand that question. Let me go quickly. Um, Sir mentioned multifocal adaptation vertical is to be noted. Assume a patient using progressive lenses come with adaptation issue due to vertical lenses. How will you tackle the same? If they already have progressive lenses, well, if you made the glasses, you have to redo the glasses, because obviously it's your responsibility to redo the glasses if you didn't detect the vertical deviation. If they came with glasses from another practice, I am by some people might find me to be arrogant, but I would write a letter to the prescribing optometrist and tell them why they're not adapting to the prism, to the multifocals, and tell them to redo the glasses. Some people those optometrists might not be very happy with me, but I tell the patients that they should go back, and this is the reason they're not adapting to the multifocals. And I don't know if they're going to be successful, but I send them with a letter. I send them with a letter and even I send them with references. The Yeah, the other day someone prescribed multifocal for myopia control, and we know a multifocal does not work. Why are you prescribing a multifocal? And I send those patients with references and to articles and a letter, and I told them they must give you the money back, because they prescribed something that they not be prescribing. So you can do that. Write them a letter. So the correct head posture is usually base down, base up, base down, base up. For vertical deviations, it's base down, base up. Sometimes I've had patients but that was very subjective, where I had to put the prism in a certain direction. But that patient didn't end up taking glasses because, but the lab could do it. So I said the base must be at 270 degrees. The base must be at 190 degree, not 90, like 60 degrees. I did that once, but yeah, even cyclotorsion, you do vertical, so base down, base up. So you correct it with base down. So you try to see which one is the hyperphoria. So the base down, and then you split the prism. So when you prescribe the glasses, if it's a two base down, you do one base down, one base up. Um, Apart from prism correction, what other therapeutic options are available to manage visual posture problem from optometrist point of view? Like I said, prism is the way to go. And if they have a very large deviation, you go send them for maybe for opinion for surgery. But vision therapy will most likely not work in these cases. So there's no other option besides prism or surgery. Um,
Okay,
is
sir.
there an
Thank you so much. So the remaining questions will be answered with the help of the WhatsApp group.
uh-huh.
If anyone have
Okay,
any question, then please type your questions in the WhatsApp group of the Neuro Optech. Then sir will answer shortly.
okay, no problem.
Yes, sir. Thank you so much, sir. As we come to the end of webinar, I would like to express my heartfelt gratitude to our esteemed speaker, Mr. Deon Hattingh, sir, for sharing his valuable knowledge and experience with us. Thank you, sir, for making the session so engaging and informative. I would also like to thank all the participants for joining us and for your active participation. On behalf of NeuroOptech, thank you everyone for being a part of today's international webinar. We look forward to meeting you again in our upcoming educational sessions. Have a wonderful day ahead. Stay safe and keep learning. Thank you so much, everyone.
Thank you guys. Thank you very much. It was a great pleasure. Thank you so much.
Thank you so much, sir.
Pleasure.
Thank you, Deon, for answering.
Pleasure.
Thank you, sir.
Thank you, sir.
Pleasure. Pleasure.